All right, so what we're going to take a look at now is how we can actually electrically measure this activity that we've been talking about with the cardiac conduction system in the heart. So we're going to be looking at what is known as electrocardiography, which is either an ECG or an EKG. Either one of these really kind of means the same thing. We're going to be looking at what the different waves on this particular thing mean relative to what's going on within the heart system. We're not going to really worry about how it actually measures this. Even I've read books on this and I still don't 100% understand exactly how it gets the reading on it. But this can show you a lot of different things about the heart. So it can show you the heart rate, what is serving as the pacemaker of the heart. Like we were saying before, is it the SA node, is the AV node? Are we maintaining a correct rhythm entry? Is there any blockages in this pathway for this depolarization to travel? Has the heart increased in size or has it had damage? These are all things that we can see with an EKG. We're going to see that there is three main waves to this, three principal things where you're getting a big movement here. You have what is called the P wave, which is electrically showing what is actually depolarization started by the SA node but is leading to that atrial depolarization. You then have the QR complex, which is basically this thing, that depolarization traveling down to the apex of the heart and that depolarization working its way up the outsides. And this is a much bigger one here. Atria are repolarizing during this, so we don't see a wave for that. But this QRX complex is that depolarization of the ventricles. It's kind of the largest event you see on the EKG. And then finally you're going to have a T wave at the end, which is showing the repolarization electrically of these ventricles at the end. We can then talk about segments in between these. So this PQ segment is the time from when we get an atrial depolarization to where it is actually working its way down to the ventricles. The ST segment is really what is going on from depolarization to repolarization of the ventricles. And again, each of these lines that are flat in between are showing no electrical change. And if you're seeing an absolute flat line in an EKG, that's saying there's no electrical activity in the heart whatsoever. We should normally see this in between beats, but you should see this PQRST wave each time the heart is going to go through a cardiac cycle. You can also look at these intervals in there. You can have the PR interval, beginning of the P wave to the beginning of the QRS. That's showing atrial depolarization and the traveling of it to the ventricle. The QT interval is the time from the beginning of that depolarization of the ventricle to it's repolarized. And again, we should see some changes in the time frames of these depending upon how fast the heart is beating, other things along those lines. So this actually shows you this PQRS T wave. You can kind of see the P wave is a little bump. QRS is a much bigger complex. T wave is again a smaller one there. So, and again, that is getting you atrial depolarization, ventricular depolarization, ventricular repolarization. The atria do repolarize. If there was no QRS complex, it would be occurring right here. The reason we know it's happening every time is there's always a P wave, which the atria has to repolarize in order to be able to depolarize. The other thing to kind of point out here is this QRS complex should be a very steep curve there, like on an A. There should be no jagged edges on it. It should go steep, back up and back down. If there's any bumps or kind of spreading this out, that means conduction is not going well down through the ventricles and could be an issue. And this is looking at electrical charge if you're looking specifically at the atria versus the ventricles, what the action potential in the, if you're looking at a particular muscle cell in there, what it would look like. And again, we are more worried about being able to identify the PQRST and what is happening during the P, the QRS, and the T parts of this wave. And again, this shows you with the actual traveling depolarization. To me, this is kind of the best image that describes this. So you can see the P wave is that depolarization that is working its way down through the ventricles. You can see it completes that. We're now getting to the AV node, and there's, you can see it gets back to flat line before it is passed through that AV node. We now see it heading down to the apex of the heart, that QR. It turns at the bottom of the heart, heads up the outsides, the RS part of this. That is that depolarization, the QRS complex. And then you can see it goes a little bit of a flat line here, and then that repolarization is going to start at the apex and travel up as well, up through the heart to get you to finish off of that T wave. We are now at a point that we're ready to start here again with that SA node firing off. Again, anything that goes wrong with these can lead to abnormal looks in what this is. So a first degree AV block, it talks about it being a longer PR interval. Again, I'm not so worried about this one, but basically it's showing you that the action potential is not getting from the atria to the ventricles particularly fast. Generally should be asymptomatic, where you get to these second and third degree blocks. Second degree block, failure some action potentials to get to the ventricles. If that happens too much, that can definitely be a problem. And a third degree block is a complete heart block, which means no action potential from the SA node are getting to the ventricles. If you have this third degree block, that is a life-threatening condition. And this you can kind of see here, this is a normal sinus rhythm, P, Q, R, S, T wave. You can see in this one, remember how I said that you could get the AV node taking over. This would be the secondary pacemaker of the heart taking over. That would be a nodal rhythm, for example. One thing that's probably not accurate on this one is it's showing it at the same pace as a normal sinus rhythm. This would generally be a slower one, but if you see a rhythm like this where there is no P wave, but it's consistent and about 40 to 50 beats a minute, that is showing you that it's a nodal rhythm. What I'm not going to do on this test is I'm not going to show you some type of EKG and say, tell me what's going on here. That is not what we're going to do on any of these ones. For some of the lab stuff, you would need to be able to identify the parts of the wave, but I'm not going to be expecting you to look at some type of heart strip here from an EKG and tell me what's going on. People go to school years to be able to do this kind of stuff. Again, we can see this atrial flutter or ventricular fibrillation on these things here. That is when stuff starts getting very uncoordinated, and you'll see ventricular fibrillation especially leads to a very wonky, non-organized curve here. So this would be VFib. It's going all over the place. And this other one here you can kind of see this is probably a secondary heart block where not every one of these is getting through. So P wave, normal one here, and then you get a P wave, no, nothing, P wave, nothing, P wave, and then the QRST coming with that. That is probably that secondary heart block where not every impulse is getting down to that. If you were getting something like this is definitely a shockable rhythm. That's where you're going to want to get it and do the clear with the paddles and get it zeroed out so we can hope the SA node takes over. And again, arrhythmia is something we don't want to have happening. Again, you get a ventricular fibrillation like that where it's that out of rhythm, you're not going to get technically any movement of any blood in these cases. And again, anything that is an arrhythmia is any abnormal conduction within the heart. This could be damage, scarring, inflammation, too much caffeine, too much cocaine, anything like that can lead to some of these arrhythmias. If we are getting beneath the normal heart rate, that would be what we refer to as bradycardia. This doesn't mean necessarily a disease state. This is just slower than normal heart rate. Endurance athletes especially tend to be bradycardic. At rest, I have probably a resting heart rate of around 49 to 50. From the fact that I am a runner a lot, probably run on average 40 miles a week. Because of that, I tend to have a lower than normal heart rate compared to a lot of people, mainly because the heart gets much more efficient, doesn't need as many heartbeats to push as much blood. Tachycardic means higher than 100. Again, not necessarily meaning an abnormal thing. It may mean you're exercising. That being said, if you are at rest and you're getting beats over 100 beats a minute, that is generally an abnormal thing, and you can start getting into issues. So supraventricular tachycardia, for example, is a resting heart rate. Once you start getting over 140, mechanically the blood can't move fast enough, and you are on your way a lot of times to a heart event if something doesn't help to, unless there is not an intervention done to help you slow that heart rate down a little bit. So that is kind of showing you each of these can be an issue. Technically, if you want to talk about bradycardic or tachycardic, you actually have to know what the pacemaker is. So this would be the numbers for the SA node. Technically, if you're having a nodal rhythm, it would be above kind of 60 would be tachycardic, and below 40 would be bradycardic if the AV node was serving as the pacemaker. But again, we're not going to worry about that too much. Just know it for the normal conditions. Sometimes people are having issues with the heart, and you can insert in what are known as artificial pacemakers. Sometimes these can function as your SA node and do that, or help you bypass some type of block that is taking place within the heart. They can generate the impulses. My grandmother, before she passed away, had one that was serving as her SA node. She was set to 70 beats a minute. Again, there's also some of these that are a little bit larger sometimes, that they can have internal defibrillators, which can sense and then act to shock any abnormal rhythm that you might be getting. So pacemakers, there's a lot of different levels to them. Smallest ones are probably about this big, quite thin. The ones with the defib built in are probably more that size and probably half an inch thick, generally implanted under the skin, under the fat, up on the shoulder region here. All right, so instead of doing a couple of short ones here, we're going to work our way into the third question, which is getting into how do we regulate the heart. We'll then move on to some other stuff after that. But not surprisingly, regulation of heart function is not going to be way different than a lot of other systems that we've talked about. We are going to see some nervous control, obviously, and some hormonal control. So nervous system control, endocrine control are both ways that are going to happen on this heart. Some of this stuff is reflexive. Some of it is in response to sympathetic, parasympathetic. And we're going to take a look at each of these things a little bit here. Sympathetic and parasympathetic control are pretty straightforward, either down the spinal cord or through the vagus nerve. Sympathetic control, increased sympathetic stimulation of the heart is going to increase heart rate, increase contractility, increase parasympathetic impulses to the heart through the vagus nerve is going to slow down that heart rate. Again, this does this by affecting that AV node and those leak channels in the AV node. The sympathetic nervous system is going to increase leak of those sodium channels, cause it to depolarize sooner, which means we're going to get quicker heartbeats. Parasympathetic is going to increase the potassium leaking back in, which makes it harder to reach the threshold, which is kind of like having that dump bucket, like I said, filling with water, but also having a hole in the bottom, so you have to keep it going a lot longer before that bucket will tip over in that idea. So the sympathetic is, again, doing norepinephrine. It is acting on the SA node. It also acts on the AV node as well as the muscle. And again, it's really going to decrease the delay at the AV node, increase the contractility overall of the muscle. This is acting on those beta-1 adrenergic receptors that we talked about back in the autonomic nervous system, where your parasympathetic is going to work on the SA node and the AV node. So it works on the SA node to slow down that depolarization. It's going to increase the delay at the AV node. What this does is overall it decreases the heart rate, really doesn't have an effect on contractility, but this is, again, working through those muscarinic receptors in the heart, at the AV node, at the SA node, in order to slow down this heart rate. We can also have some kind of reflexive actions that are taking place in here, as well as just higher level brain things. A lot of times will influence heart rate. If you're nervous, if you're upset, you're embarrassed, this will affect heart rate. So that cerebral cortex can influence through the autonomic nervous system your heart rate at some level. Your thalamus, realizing you're moving more, can also do this. So the sympathetic and the parasympathetic centers are really in that brain stem that control getting down to that autonomic nervous system. Again, increased temperature, exercise, anxiety, these are all things that kind of coming from the cerebral cortex, or the fact you're getting a lot of sensory impulses, that you're moving a lot through the thalamus. These are all things that could trigger an increase in heart rate. Increased temperature is going to increase heart rate, trying to move that heat around and dissipate it. The other thing we see is some neural control via reflexes to make sure that we keep our pressure high enough so we don't lose consciousness, or kind of keep us from getting too high a pressure. So we have baroreceptors, which are pressure receptors in the aortic arch, as well as in the branches of the carotid arteries. These are stimulated by the stretch of these blood vessels here. So if you're getting too much stretch, what can happen with these baroreceptors is it can feed back to the heart and saying, okay, we're overstretching these areas. Let's decrease the heart rate, decrease the contractility, which means less blood coming out of the heart, which means less pressure on these vessels here. It is a short-term way to drop blood pressure. The same thing can also happen in response to you sitting down and standing back up. You're going to get a decrease in pressure on these things. That will increase heart rate and increase contractility to make sure blood keeps getting up to the brain so you don't lose consciousness. If you've ever stood up real fast and get a little woozy and then it comes back, that is a baroreceptor reflex in the opposite direction of this one that's helping to bring blood pressure up so you don't lose consciousness. The other thing is different chemoreceptors are also present in these areas, looking at blood acidity, looking at carbon dioxide and oxygen levels. Anything that is showing decreased oxygen levels and increased carbon dioxide, which would coincide with a dropping pH, a more acidic blood. These are all things that would increase heart rate and contractility to try to make sure that we're moving enough blood to the lungs to get rid of this oxygen, to bring in more oxygen and get rid of the carbon dioxide. Again, not as key, but if you were to hold your breath a while, you would see an increase in your heart rate because of that. The other thing is, with the fact that you move a lot more, if the body is recognizing proprioceptively that you're moving limbs a lot more, it is going to increase your heart rate probably before the need occurs in terms of lower oxygen levels at those muscles. So the fact that you're moving a lot of stuff here is going to say heart rate goes up, I need to go up because we're moving a lot more. We're going to be calling for more blood to these skeletal areas here. And one of the ways to get more blood to areas is to increase the output of the heart. That is something, at least in terms of output, we'll be talking about at the end of this, talking a little bit about the factors that influence what we call cardiac output. But proprioceptive reflexes are definitely something that is going to increase heart rate and contractility, increase our output from the heart. There's also a number of different hormones that can influence this, either through the autonomic nervous system. We know epinephrine, norepinephrine is going to. If your adrenal glands dump a bunch of adrenaline, i.e. epinephrine, norepinephrine, into the bloodstream, this is going to increase your heart rate. This is going to increase heart contractility. This is part of the reason sometimes if you get scared and you get a big dump of adrenaline into your system, or you're almost in a car accident or something, you almost get in an accident and all of a sudden you're like almost shaky and feel like your heart's pounding out of your chest. That is the fact that you dumped a bunch of epinephrine into your system, and then it's going to increase that heart rate and increase that contractility. We've talked a little bit in the last chapter with the endocrine system about the thyroid hormones, but those different thyroid hormones, the T3 and T4, are both going to influence heart rate and increase heart rate if they're at higher levels in the bloodstream. So that is another way hormones will upregulate this function here. And those are just a few of the examples that I wanted to talk about on this. What we're going to be looking at the rest of this a little bit more is we're going to do a couple of different things towards the end of this. We're going to look at cardiac output as well as kind of how we get blood flow to the heart. What is the kind of the anatomy of the blood vessels to the heart, that coronary circulation. So I will see you then.